Good morning, folks, and welcome to the Palliative Care Friday Chalk Talks. Today we have a discussion on occupational therapy and how to best utilize it in our palliative and hospice population. Our guest today is the outstanding Dr. Janice Kishi Chow, and she holds clinical and research doctorates in occupational therapy with emphasis in end-of-life care. Her clinical experience in occupational therapy spans 27 years in physical medicine settings and includes 20 years specializing in hospice and palliative care at the VA Palo Alto healthcare system. Um, Her mission is to improve quality of life at end of life by making occupational based interventions accessible to people living with terminal illness. Welcome, Janice.
Great to be here. Thank you for having me.
Absolutely. Our format for today is going to be an interview format. We've got about 5 questions. We're going to focus, I think, mostly on understanding and dispelling some misconceptions, and then we'll open it up to questions for the audience. So we'll jump right in. Janice, start off by talking to us a bit about some of the biggest misconceptions that you see in OT in the hospice and palliative care world.
Yeah, I think, the biggest one is that to assume that we all just are in rehabilitation and that's all we do. And that equates then to cure that so in that way people think, oh, occupational therapists only get people better and my patient is not getting better. So we don't need occupational therapy.
Mm.
I think it's the misconception that we all only there for rehabilitation. I think the second thing that comes up too is that thinking that we're kind of a type of physical therapist. We're not a physical therapist. Like, oh, I just need upper extremity exercises and things for the hands. I said, oh, we're not just that. We actually do a lot more than that. And if we were a physical therapist, we would call ourselves a physical therapist. We're an occupational therapist. So that those are like I think the two main things that come up, misconceptions.
Uh, Before we move on to number two, interesting that you used the word better because better, boy, can mean so many different things to different patients. And I hear when you say better, you're talking about like cure, get stronger. You're thinking, and when I hear better, I hear better in the palliative care sort of term. Like maybe there's something from a quality of life perspective. And in that perspective, maybe you do help people get better.
Yes. And I thank you for defining that. I think within this group, it's preaching to the choir. I think a lot of people understand that, and I think, but a lot of times when there are doctors outside who have patients who are at the end of life, but they're not in a palliative care setting, which there unfortunately there are a lot of people who don't get palliative care, right? And they're in acute rehab and they have congested heart failure and they just keep coming back in and out. And yet you know, they're at the end of life. No, they don't need any more OT and they just discharge, right? So yeah, it is the word better is often associated with cure. And then they associate that's not what we're there for. Unfortunately, there are some doctors within hospice and palliative care who feel that, well, you can't, they just equate it strictly with rehab and therefore it's not really appropriate for my patient. And so then they just don't really associate with that quote type of better that you're talking about of quality of life and exploring that more.
Yeah. So so when goals shift from that life prolonging to more of a comfort care, in my world, in the hospital setting, I often will see OT, PT teams signing off. And maybe that's because of workload, right? Limited resources, but maybe that's also because we as the clinicians are not specifying how we want OT and PT to shift their focus. How can we as clinicians better communicate with those services? And do you think practice can actually change?
Yeah. I think too, just going back to your first
Mm,
statement, just that
mhm,
people signing off, I think it is very limited to where a person is working.
mm,
So there might be constraints in terms of what they feel that insurance will pay for, or the purpose and the mission of what the facility is doing. And so it could be, even though an oncology rehab setting is working with patients who are living with life-limiting illnesses, they might use again that word rehab that we are only getting better, and this person is no longer getting better, and so they were gonna
mm,
discharge them to hospice. So everything is just kind of withdrawn because it's seen as part of that cure package. And so I think it is a cultural culturally defined oftentimes within a setting. And when those themes of care happen, there is the need to make those conversations happen, to really adjust language to really fit the needs. And I think your question is I'm very thankful for that question that you're posing, because
Mm,
not a lot of people do. They don't ask, like, well, how could I see what you can offer. Help me, help me help you. So, and make this better. I think there are occupational therapists and physical therapists too, who don't understand what can be done with people with life limiting illnesses, and I'll just own it, that they're, and just like physicians specialize in different areas of care.
sure.
There's OTs and PTs who also, and speech therapists who specialize in different areas. And if they are just a rehabilitative therapist, they might also just discharge. And I have done that too when I was working in acute care. Um, and so, but it does take a shift of saying, um, I am not asking you to rehabilitate. I'm just asking you, can you help this person still participate in something meaningful? Can you help me problem solve and figure out a way that we can still adapt and modify? Those are really big, I think, words that OTs latch onto. Like, oh, okay, you
Mm,
want me to help you adapt and modify? I can do that.
mm.
I can figure out ways to adapt and modify so that this person can still do, and you fill in the blank. And then also saying, like, I'm not really just saying just self-care, that feeding, dressing, bathing, those basic things that OTs often do. Can you help them be able to still engage with their children, their adult children? Can you still help them when they go home, feed their dog or walk with their dog? Can you still help them be able to figure out a way that they can bring closure to this time in their life? I think they have some affairs that they may need, and not necessarily financial affairs that they need to go to a social worker with, but
Mm.
is there something that they could put things that will leave a legacy together, and as they're trying to bring closure, that is their occupation at that time. How do I bring finality to this time with purpose and meaning? Please help me figure out. So again, going back to your consult question, it's like maybe saying, can you please help me problem solve ways that we can keep this person able to be a part of things that's important in their life? Um,
Yeah, it feels like the OT consultant can help explore some of their goals. What's important, quality of life from sort of that niche and sort of build upon what we're doing.
Yes. And I think there's a thing about, so occupations are anything that is purposeful and meaningful that we do. And they could be as small as brushing our teeth to like running a Fortune 500 company, running a household, and being a parent. And so they are just really complex things that we do inherently and just unknowingly that we do, but also it defines who we are and how we're connected to other people. And so yourself as a doctor, myself as an occupation, but also other things as a parent, as a friend, as a person who always has the great punchline that comes back, or the glue of the family. Those are our occupations that really define how we
Mm,
connect to other people.
mm,
And when we lose the ability to do those things, we lose the ability sometimes to connect to people. And as you had in your podcast a couple of weeks ago, you might have a social death
mm,
before you actually have that physical death.
mm.
And so what can we do to help people still figure out ways to be connected to their occupations as they decline? But also, can we help them explore new ones too that may fill that void as they're going into another stage of life? And
Mm.
how can we tap into new things and explore? So it's like, can you help OT? Can you please help us explore new occupations for this person? Is that possible?
Yeah, adapt and modify. I like that.
Yes, yes, adapt and modify. Yeah, yeah.
So, of course, I admit, yes, more often than not, when I think of OT, I'm thinking of the physical body, and yet, as I read more and learn more about OT, there's some crossover with sort of mind body. Um, can you talk to us a little bit more about that, about how OT is not just sort of the physical?
Sure. Yeah. I think a lot of people don't know is that occupational therapy really differentiates itself from physical therapy, in that we started out working in the mental health setting. We actually have our grassroots in mental health. Our groundbreaking point is actually serving with veterans who came back, quote, shell shocked, or what we now call as PTSD, from World War I. and that they found that when they were able to engage in something purposeful and meaningful, and at that time, sounds very dated, but it was working with leather working and weaving, basket weaving. But when they were able to do something like that, they were actually more focused, able to connect with other people, be a little more calm and grounded. And so that's kind of like, even though it may seem such a long time ago, it's still the premise of who we are, is that what can we do to help people still engage in something that helps them be able to be connected to the rest of the world. And that way we also are, so we're very psychologically minded. We also look at the cognitive aspect as well as the physical within the context of the environment. And so we're looking at all these things at the same time. I think, and so that's part of our assessment process, is to look at all those things. And so when you talk about the mind body, we might use interventions such as, yoga or mindfulness of Tai Chi. There's some, but not all OTs are trained in those areas, but there are some OTs who are trained in those aspects to use them as modalities to help with that psychosocial aspect. And so that's why you see OTs in mental health that might work with stress management, social skills, how to deal with anxiety, but also translate to end of life, is what are we doing to help people deal with the stress of dying and dealing with the context of dying. So it could be as much as doing mindfulness and breathing and helping them, and also working with our psychology partners too, to really just help people deal with the stress of dying, dealing with interventions, dealing with pain and suffering, or helping their families as well still remain connected while dealing with those aspects.
I've never consulted OT for a patient that has really complex total pain, complex suffering, even though I'm addressing some of the physical pieces, and there clearly are some other components, some psychological components. Maybe that is something worth exploring in the hospital.
Yeah.
Okay.
Yeah. I
Hmm.
think too, like sometimes when they have really severe pain, I have to wait a little bit until the doctors and nurses really get in there, pharmacists get in there and
Sure.
kind of titrate everything. But at the same time, if that person really needs to still feel like they need something to help their mind go other places, and it could
Yeah.
be as simple as getting them set up so that they could use their phone to do FaceTime and have a setup that they can do it, you know, um, it could be as simple as getting modifications so that they have the thing that's holding it up for them so they don't have they can do hands free. But yeah, it may be worth exploring. And yeah, you can actually let them know they have really severe pain. Can you tell me if there's anything that you can help me with? If as it gets more controlled, can you come in later on and really help them still explore different things and help them still be engaged in life?
Wonderful. So are there limitations to OT, patients that are unlikely to benefit, or even maybe patients that might be harmed by OT?
Yeah. I think for one, if the patient doesn't want to participate in OT, I think that comes
Mhm.
up a lot, because we have well-meaning family, friends who really still think, well, if they get OT, they'll get better and they won't die. And that might be their underlying. It may not be that blatantly, but then I get families who get really angry, like, why aren't you showing up? Because the underlining is like, you're not showing up. My dad's gonna die because you didn't show up. And so, but then when I go talk to the patient, there's like, I really don't want to be doing this. And I was like, that's okay. And I'll just try to give voice, and there is therapeutic value in allowing someone to say no and allow them to have autonomy and agency in that way and advocating for them. So I think they it may be just that they don't want to participate, and really delineate, just really finding out whose goals are we really serving and try to serve who what the patient really wants to have happen. I think the second type of patient is the one that's not able to engage, where they're either um, they're not alert and oriented, they're confused, they're not able to really engage meaningfully, um, and that they may be combative as they're going through the end of life, and they may be because they're having other symptoms that are just really difficult to manage. Sometimes nurses want me to come in because the patient's just really restless, but they're not even able to follow directions. And so we're still helpful in that we might be able to work with the team to modify and adapt the environment to make it safer for that person. We can look and assess the area to see if we go, are there certain obstacles that may trip this person or cause them to fall when they're agitated? But also looking at and discussing with the team, are there certain cues or ways that we are communicating with that person that agitates them? And, so it's not necessarily working directly with the person, but thinking about the environment to work with the team to see like, oh, is there something that we can problem solve together to make it better for this person, even though they're not able to directly benefit from occupational therapy, that maybe we could work with the team to make the environment more supportive of where that person is at. Um, I think too, so then there's a next, I think another category of where it may not be, it may not benefit is that the expectation is to cure. So I'll often get people say, oh, this person, if you just go in and rehabilitate, work with them, and then maybe they can get stronger to go have more chemotherapy. And I always just say, preface that, um, I don't want to set the expectation that I'm going to get you better or get that person better. And that might be even a team member consulting me of, that's not necessarily in hospice and palliative care, but they might just say, if they just get some rehab, maybe they'll get better and then be able to move on to the next stage of disease modifying therapies. And I don't like to set that person up. That just really puts them up for failure. And I just try to say, OT doesn't cure, it won't take away this cancer, and I wish it did, then everyone would be using OT, and it'd be really awesome, for that purpose, right? But then it is just to see, I just say, I'm just here to just try to find out what you wanna do, if there's something, and if we can try to figure out ways that you can still be able to be part of those things, and if not, try to find something else. So I think in that way, it can be not beneficial if the person has false expectations and we get set up like for disaster in that way. Um, and I think the other one where that I think is where physical harm can happen is where, um, and this is up to the OT. Is really working with our physician colleagues is saying, are there any precautions or with the disease that we have to be careful with? And so I think a big one that comes up and working with our veteran population is that we'll have a lot of gentlemen who have prostate cancer and the cancer has metastasized to the spine. And I'll look at the chart and they'll just say, oh, please, OT valence/treat. And I'll say, oh, the orthopedic and neurosurge, they've already signed on saying that there's vertebral fractures. This person has a cord compression. Do you have any precautions that you want me to, be mindful that this person could have a severe spinal cord injury if they're working with me? And then, so those are things that, have to be spoken about with the patient and understand the risks and benefits. A lot of times in, end of life care, people don't want to be restrained, be braced, have all those things, but it still warrants a conversation that if you're not wearing your, thoracic lumbar sacral orthosis, you might have, more cord compression or even a very severe spinal cord injury that may leave you, paralyzed from the waist down. If you're getting up and doing these things of this level of activity, are you okay accepting that, those risks? And so that has to be documented and to know that those things can happen. So it's a team effort to really, because I really look to the doctors to say, what is going on physically as the disease progresses? Please guide me in knowing what is safe and what is possible and what the person needs to be aware of the risks of doing. So,
Yeah. I've got just one more question. I want to let the audience who's here today know that if you have a question, you can either put it in the chat or if you want to use your raise hand function, but you've got a minute or two to consider it while I ask my last one. So, um, last one's about hospice, right? Talk with us about OT and hospice, because the more I hear you talk, the more it sounds like PT should just be a part of every palliative care and hospice team.
yeah, I think OT, I think it's, I think that the thing about to remember about occupational therapy over every area that we work in, every population that we serve, what our basis premise is that we use occupation to help people have health and well-being at every stage of life. And so that being able to be engaged in meaningful occupation, which is meaningful, purposeful activity that really grounds us and connects us, is what we're all about. And so when you put that paradigm in end of life care, it's trying to figure out, as this person is physically declining, how is that affecting them physically, emotionally, spiritually? How can we still help them be able to participate in what is meaningful and purposeful? And so, going back to just thinking about, even though I may not be able to rehabilitate a person as they're declining, and can I help them modify, adapt what they're doing? And it might be giving them a gadget to be able to put their socks on, or be able to brace big handles so they could still feed themselves. It may be working with the environment, seeing like, oh, is there a wheelchair accessibility? Can I get them a wheelchair that's more comfortable for them, or help them work with power mobility, or even broader out to the physical, the social environment too, working with families. Can I teach them how to work and provide safe care as that person is going through the end of life, but also to think about how their social skills and how they're able to give them ways to still connect, talk to with one another and be
Mm.
present with one another, give them different and ideas and how they can do that. So, yeah, please consider using an occupational therapist in end of life care for not only, just not just physical, but the psychological, social, spiritual aspects of the dying process, to be connected with their occupations. I think not all occupational therapists are aware of how to be used in this area. And if you are in a setting like home health, not all home health therapists know, because they're still in that rehab mode of trying to get people going. It's just really rewording the consult to say, can you help me modify and adapt so this person can still remain engaged? And I'm not looking for you to rehabilitate and cure this person, but
Mhm.
just help me figure out problem solves ways. Can you just help me problem solve ways for there to still be engaged and participating in life?
Yeah. Thank you. I want to read back some of the little tidbits I wrote down. I mean, OT is adapt and modify, promoting autonomy and agency, participating in what is meaningful and purposeful, improving quality of life, and promoting connection, avoiding social death. I mean, you guys fit perfectly within our palliative care and hospice world. Have you ever been on a team, a palliative care team, where there's been a dedicated OT as part of that team? Because that sounds like a lovely addition.
Yeah, I've been very fortunate, because I've been working at the VA, Palliative VA Hospice and Palliative Care Center the last 20 years,
Mm,
and I believe they've been around, I think even 20, 25 years before I got there.
mm,
And so that team actually had to make a choice when they first started out with their funding, that they only had a part-time FT or full-time equivalent for one rehab person. And so they had a choice between, PT, OT, and speech. And I was very grateful in that for our for founding team
mm,
members, that they chose OT because they felt OT would be the most flexible and be able to do, because we do things like functional mobility, and not an expertise in exercises, but we could still get people up and going. But we still do in the self-care, but we also do the psychological too. And so there's just this holistic thing that
yeah,
I think, especially in the context of decline, physical decline,
mm,
OTs are really, really good for that. So I'm actually I was the only quote allied health person for a while. And then now we have a recreation therapist, and we're both just part-time, and we have a massage therapist, and we are the allied health presence on the team, which is very different, I think, than most rehab teams, right? And I think it reflects so much about what our focus is as a team. And I'm very thankful that my team understands what I do, and what we can do as allied health professionals together. Um, yeah.
wonderful. You've answered all of our questions. We've learned a tremendous amount today, Janice. Thank you so much for joining us.
Oh, it's my pleasure. Thank you so much for having me. Thank you very much.
Absolutely. All right. Have a wonderful weekend, everybody.
Yeah, thank you.
Bye.
Bye.